It's a hot day in Rome at ESC 2016, and the CardioSource World News cover story for September is risk scores. And so what I'd like to do is to focus on one specific one, Syntax Score 2. And it's from the JACC Cardiovascular Interventions issue of August 8th, and I am so happy to be here talking to Dr. Patrick Serruys, who's an MD and a PhD and a world-renowned interventional cardiologist, currently Professor of Cardiology in the Cardiovascular Science Division of the National Heart and Lung Institute of the Imperial College in London. Okay, we understand the emphasis on the heart team. I mean, that is very, particularly the ACC, that's very important, and the value of the syntax and STS scores to guide the decision regarding optimal revascularization. So what you're looking at here is Syntax 2 and an external validation particularly. What should we know about Syntax 2 before we talk about validating the
That's a good point. It's of course a long story. I'm afraid to say that, but it's a long story. When we did the Syntax study, Frederick Moore, the great surgeon from Germany, said, I don't want cherry picking, we are going to have an all-comers patient. Nice. And that was a good principle, but we had to develop a tool to force the surgeon and the interventional cardiologist to look very, very carefully to the film.
Right.
And we created a syntax score. I put together all the score that I could find, and we end up with numbers, and we had not the slightest idea what it means. We had a syntax score of 40, 20, 80, etc. When the study was finished, we realized that the syntax score has a strong prognostic value, and we made that classification, 22, 33, two numbers, easy to remember for the surgeon and for the cardiologist. We discover also that if the syntax score, so the anatomic assessment of the coronary circulation, was very important for the interventional cardiologist, the surgeon was basically immune for that kind of things. You know, they have a bifurcation, they bypass these things, they don't have to go through. But on the other hand, we realized that in terms of Euroscore, STS, logistic Euroscore, they have to pay the bills if they were comorbidity. So my dream was always to put the anatomy and the comorbidity together. And at the end of the syntax study, we had the syntax score 2, which is the classical anatomical syntax score, plus a certain number of key elements. Gender, age, ejection fraction, creatinine, peripheral vascular disease, COPD, and a little bit diabetes, not too much. And then we put these things together, and to our surprise, we could predict the mortality at 4 years with what the statisticians call a good calibration and a good discrimination. That's a story of the syntax score 2. And then, of course, we validate that first time with the Kyoto study, and then most recently we validate that again with the study that have been conducted in Korea, pre-combat.
And the best trials. Now, those were a little different in terms of the patients, so can you describe the patients who were in those two studies?
Yeah, I mean, every time that you try to do globalization, and in medicine we do also globalization, and you try to work with the Far East, the United States, Europe, there is not too much difference, to be honest. But when you go to South America, South Africa, or Far East, there are difference in the skill of the operator, a surgeon and interventional cardiologist, but also in simple things like BMI. So yes, I must say that the calibration and the discrimination has suffered somewhat from this expansion to another continent. That, I think, is the message that we can remember.
So what did you learn from the analysis?
From the analysis, we learned that it's still working quite well. I mean, I'm not going to destroy the instrument publicly. It works quite well. I think that we have to make clearly the difference between three-vessel disease and main stem. And the three-vessel disease will remain for a long time the field of the surgeon. It has been confirmed that we do quite well in the low anatomic syntax score, but above 22, which is in the guideline of the European Society, JACC, we do less well. The main stem, that's another story, and I think it's not finished. Because just after this paper, there's another paper in JACC with an audio Valentin Förster, when we look only to the main stem, okay? And then it is very surprising to see that basically 2/3 of the main stem going to a score of 32, do very, very well, not only in terms of mortality, but in terms of MACE, including revascularization. So that's an important message, and of course, we are all waiting for Excel at the TCT, which is main stem versus intervention. I must say that submitting that paper, combat and syntax in main stem, I suggest prudently to Valentin Förster, maybe could be preview of Excel question mark, but we'll see, we'll see. He make a nice answer. He said the author cannot suggest the title of the editorial. It's between us.
Answer, yes. Now, John Hirschfeld and Matthew Seybold wrote an accompanying editorial comment to your paper, and they noted your choice of all-cause mortality as the analysis endpoint, even though additional endpoints had been recorded in these source studies. Why did you choose all-cause mortality? Is there more you can learn from the data?
Yeah, you know, I've been a trialist for a long time. I mean, I've done 5 or 6 trials with the surgeon, and I'm still doing. My first was Cabri, where we also start by just counting the dead bodies. That is, I'm sorry for the expression, but it's the most easy things to do. You can contact a website for the vital status. After all, after surgery or PCI, if 5 years, 10 years down the road you are alive and with a certain quality of life, you will forget a lot of things, including the sternostomy and many other things.
Right.
So for me, mortality is the essence of the goal to be achieved. Why we didn't take MACE? Because there is a kind of flip-flop there. I mean, what I mean is that the surgeon gets some more stroke. Okay, you have the off-pump surgery, but when you are on-pump surgery, you touch the aorta and then you are in trouble, and they had more stroke. And on our side, interventional cardiologists, we have more myocardial infarction. So they were a factor playing against the surgeon and against the interventional cardiologist. The common denominator was he's alive and he's doing well. So that's the reason why we took mortality. You cannot cheat with mortality.
Yes, this is very true. I like syntax too because you show that you're a little bit more towards PCI or a little bit more towards CABG or equipoise. Yeah. So you do give them that choice of, according to the score, let's talk about with the patient, what do you want to do?
You know, I work a lot with top epidemiologists, Professor Steinberg and others, and of course these guys like the concept, not 95% confidence interval, they will disagree with you, they call that 95 PI, prediction interval, that's a new term. So the equipoise is, of course, with a large 95 prediction confidence interval, but nevertheless, there are clearly a cohort of patients who has to go to surgery. Right. It will be almost criminal to do something else. And we have a study in Serbia where they have no surgery on site and where they do their own assessment. And for them, it's very useful to use the syntax score too, because they can see where they should not go. I mean, the case that really they have to submit to the surgeon.
So what's next? I hear there's a syntax 3.
Yeah. You know, the point is, people said, there's 2 new things. People said interventional cardiologist, but the surgeon also, is jumping on everything which is more or less 50%, okay, diameter stenosis. Right. And it's true that over the last 2 decades, we have made this effort to have a functional assessment. It's becoming a little bit complicated these days, but let's say that the FFR is quite robust and has proved that short-term and long-term you can make a selection and avoid to make unnecessary treatment, surgical or interventional. So we talk about the anatomy, we talk about the comorbidity, which is playing against the surgeon. Now we want to select really the lesion that need to be treated, that need to be intervened. And that's the combination of all three is the syntax tree. So simple is that.
So when will this be more available, shall we say?
It is on the website since May, the syntax score 2. We have finished the study called syntax score 2, who used the syntax score 3, in the sense that we had a population of 450 patients where we did IFR, FFR in every vessel. And we use IFR because with FFR you need adenosine. You know, it's very unpleasant feeling of dyspnea and so. So that trial is finished. I presented the 30 days to expose the trial at EuroPCR, and it will be next year the final result to see the combination of the anatomy, comorbidity, and function, if we can be more precise in the medicine. You know, precision medicine is the key word these days. So
you got that right. And to be precise, we want to make sure that they know to look at JACC as well as JACC interventions for these two papers.
Good.
And also, while you're at it, please look at the cover story for CSWN as we take a look at risk factor scoring. And it's a great cover. Deborah, I think, did a wonderful job. For Cardiosource World News, I'm Executive Editor Rick McGuire.